Hi friends, next part in the ECG summary is ventricular arrhythmias. First, we will learn about premature ventricular contraction. Broad QRS beat coming in otherwise normal rhythm, it is not through common usual conduction. Ectopic beat dangerous if it occurs often, may interrupt the regularity of underlying rhythm. P wave will not be one before ectopic beat. Next is ventricular tachycardia. Ventricular tachycardia can convert into ventricular fibrillation, which is more danger. It is combination of 3 or 4 beats with broad QRS and regular rhythm and fast rhythm. Polymorphic means beats of different shapes. Monomorphic means beats of same shape. Polymorphic is different shape. So in case of ventricular tachycardia, we should see pulse of the patient. If there is no pulse, pulseless ventricular tachycardia, we should give shock to the patient. Next is ventricular fibrillation. Here, no beat of ventricle. It is most disorganized rhythm on ECG. So ventricle flaps like wings of bird and coarse and fine VF. So here, this is ventricular fibrillation. VF is shockable rhythm. We should give shock to the patient. Shock, CPR and epinephrine are to be followed in order. So this is fine ventricular fibrillation. Next is AV blocks. First degree AV block, there is slight conduction delay at the AV node. Second degree, some beats are allowed and some are blocked by AV node. Third degree, there is complete blocks and there is no correlation between atria and ventricle. Here, first degree AV block, PR interval is prolonged, that is more than 0.2 second. Second degree AV block or Mobitz type 1, successive longer PR interval prolongation occurs until one QRS fails to occur. Mobitz type 2, suddenly dropped QRS with PR interval normal. QRS is often abnormal. Third degree AV block, there is no association between atria and ventricle. So here PR interval is more than 0.2 second in first degree. In second degree, there is prolonged PR interval until one QRS is dropped. And second degree heart block type 2 Mobitz 2, fixed PR interval will be there and dropped QRS complexes will be there. Third degree heart blocks, equidistance from each other, each wave, and P waves march through the QRST complexes, regular PP intervals unrelated to regular RR intervals. This atrial contraction is not corresponds to this ventricular contraction. They are unrelated. Next, myocardial infarction. Myocardial ischemia is not enough blood flowing to heart muscle. So there is ST segment slight depression 1 mm or more below the baseline from 0.04 seconds from J point. With or without T wave inversion, ischemia may occur and go with angina or during stress test. Ischemia is heart muscle and angina is patient compliance. It is non-ST elevated MI. Injury is prolonged ischemia. Cause is no blood flow. So injured area remains electrically positive, causing ST segment elevation 1 mm above the baseline in limb leads and 2 mm above the baseline in chest leads. 0.0 seconds, 0.08 seconds to the right of J point. Look for in 2 or more leads first in same area. Infarct is dead tissue. Deep Q wave with significant Q wave will be there in case of infarction. May or may not be present Q wave in case of infarction. ST segment and J point, normal anatomy is, so this is J point, this is Q, this is R and this is S. So here this is isoelectric line. J point should be on the isoelectric line. and normal QRS width is less than 120 milliseconds, and PQ junction. So how to assess J point whether it is in isoelectric line means we should observe PQ junction. It should be in same line. And ST segment is usually slightly upwards. Here slightly upwards, and T wave is usually upright, and AVR everything is reverse. So ST segment is here to here. This is ST segment. Beginning of ST segment is J point. This is T wave. Here there is J point elevation. This is isoelectric line. 4 small boxes equal to 4 mm ST elevation. Here from isoelectric line 3 small boxes equals to 3 mm ST depression. So normal T wave is nice round convex appearance. This is biphasic T wave. This is notched or bifid T wave, broad slowly generated T wave, flat T wave. Hyperkalemia will cause this T wave appearance and prolonged QT interval, and this is strain pattern, and this is ischemia T wave. This is early repolarization T wave. So here if you see, usually it is concave. If it is obliquely straight, this is ST elevation, and non-concave or convex also ST elevation. This is typical of ST elevated MI. Thank you.